Can we move on to the first substantive item, which is the quality report that Cathy's going to lead on now? I thought it was really important to get two big and chunky substantive items on the agenda, and I think the two most important ones to us are the quality agenda and the productivity agenda, and I think we need to look at both those two things together. So if I can ask Cathy to introduce the paper. There's not going to be a specific decision required on this, but I want to use the time for the board to really think and focus on the equality agenda and how we can move that forward. So Cathy.
Thank you. I'll kick off, but then I think Ruth will also assist me in this. So, as you say, Chair, the board has been obviously very interested in the quality agenda. It is one of our 5 key themes, and almost kind of our purpose of being here is to ensure we have high quality for patients. So hopefully the paper sets out really our approach, and we've set that out in terms of our approach within the sector, but also across the system, particularly around safety, where we have got some broader responsibilities. Interesting, I think, just as a background, it's worth noting that in spite of the pressures that Jim alluded to, overall the quality across the NHS and in providers has tended to improve, and some examples there around stroke, cancer and so on, the outcomes are actually getting better. At times it may not feel like that, but this is actually what is happening. And then in terms of some of the sort of major safety improvements, I think Ruth will come on to some of the specifics around that shortly, but again we are making progress. We thought it'd be helpful to remind the board that we are, as NHS Improvement, part of the National Quality Board, which is the overseeing body, if you like, brings together all the arm's length bodies that chaired jointly by Bruce Keogh and Ted Baker from CQC, where we try and take an overview of quality across the system. And the shared commitment to quality we publish jointly from the NQB, and the definition of quality is in the Appendix A. So just quickly, in terms of our oversight, you'll be familiar obviously with our single oversight framework, in which we include elements of quality. We rely quite heavily obviously on the CQC's ratings of organisations, but we also have our individual metrics, and those are attached at the end, but I think Ruth will refer to that. And then obviously we have some specific areas of quality that we are very focused on. Our trusts that are in particular difficulty, special measures or challenge providers, we work very closely with those, and you can see here that over the last period quite a number of trusts have been in special measures, in fact 35 overall, and there currently are 15, and we are making progress with those. But that's an area that we particularly focus on, work extremely closely, not just with CQC, but with other arm's length bodies to take that oversight. We have an ambition to reduce those trusts to 0 by 2020, which is quite a challenging ambition, but one for which we feel we are on track. We're not just focused on the most challenged, we are focused as well as helping organisations move to good or outstanding, and we have a well-developed programme now to assist that, and so far this year 9 trusts have actually made that journey from requires improvement to good. Patient safety I'll just say a little about, because this is the area that we have some statutory duties that sit across the whole system, so we're not just looking here at providers, hospitals. We are responsible for safety across GPs, community and the whole system, and there you can see in the paper at 21 there are 2 particular statutory duties that we have to deliver. And as you will be aware, we are out to advert for a new National Patient Safety Director, so that will be an important appointment to take that programme forward. And then finally, before Ruth comes in to give a little perhaps on some of the particular safety challenges and ambitions and some of the metrics, we've talked before about setting up a quality committee as a subcommittee of the board, and we are in a good position on that. Sarah has agreed to chair that, and our Darzi will be a member of that committee, and we are hoping, well, we know that we will be meeting in October for the first meeting, and then the board will get more detail, I think, that comes through that examination of our quality ambitions. So,
Just very briefly then, about in Appendix B, you'll see the measures that we are proposing to work within this quality committee and our overall approach to quality. This is nothing new to providers from whatever sectors, but we've got our measures that are going to be for all providers, which is important that we look at not just what's in the inputs but outcomes for patients and of course for staff, and that's really important for all providers. And then it's also segmented then by different types of provider, whether it's acute mental health and the like, ambulances, and then of course the type with the CQC domains, because we want to make sure that we can cross-reference it to the caring domain, the safe domain, the effective domain of the CQC. Really important that we're able to connect back to CQC, because that will help us then support trust with special measures. You'll be aware through other reports like the improvement report that all of the ambitions and the work programmes that sits across all of our directors, but particularly Cathy and I, with supporting trusts with either their infection or their falls or learning from deaths. All of that then is the supplementary information, supplementary improvement work that we do jointly with the regions to support organisations. And lastly to say is that on our travels last week, I think it was, Cathy and I presented to the Chair and Chief Exec's community of providers with Dame Gillian chairing it, and it was a good opportunity for us to set out what we've learnt over the last year as leaders clinical leaders of this organisation. What were the three things that we learnt? And we learnt much about leadership, engagement of staff, and then the quality improvement methodologies. We were able to share with chief execs and chairs across the provider units those of our personal lessons learned, some of the work programmes we were doing, and of course the measurements. So it was a useful timing that this has now come together. I'll stop there, and we'll of course take any questions between us.
Okay, now I'd like, because I want to give a little bit of time to this, I'd like to try and structure the discussion as best we can around this. So I think if we could start off with if there are sort of any general questions, points for clarification from people about what's in the report or what's just been said. Perhaps then we could think a little bit about the measures that are there, the measures that approach the single oversight framework, and particularly from that how we as a board build that measurement into our discussions, how we use that along with the measures that we already have for finance and operational performance, and how we use that as a board. And I think it's worth us spending a bit of time on that, and as a board, within that, how we assure ourselves about quality and safety. So we do that as the sort of second chunk of the discussion. And I guess the third chunk of the discussion perhaps then might be around, well, in the light of what those indicators are showing to us at different times, what are our interventions, how effective do we think our interventions are? Now, if other board colleagues are happy with that approach, I'll try and sort of work around that. So first of all, anything that people want to raise in terms just of questions, points of clarity, things that they... Sarah?
So I'm sure I should have known this, but I don't think I had focused before on the fact that we had responsibility for patient safety in primary care, and you specifically mentioned GP practices. And I have no idea what our method of doing that is, because I didn't think we had any relationship with GP practices. So it's perhaps just something to clarify for me.
So should I try and answer that? So the statutory things, as I say, are in 21 there. So it's really that we provide that in terms of information and the collection of incident reporting, and when we send out alerts and that sort of thing, we do it across the whole system. Within the patient safety team, there are experts in general practice and so on that are able to link in and do that. And we also work through and with NHS England, who do have the oversight of those parts of the system. So it's not huge numbers of people we've got who are working directly with the GPs and so on, it isn't quite like that, but we have a responsibility to make sure that the advice and guidance that we gather, the information and the incidents and so on from across the system.
So we send advice and guidance out, and we collect information, reports of incidents that have happened.
Yeah.
But we're not responsible ourselves for. We haven't got a responsibility to have prevented those or
So we're
to
not
be liable for them.
No, so we're not directly responsible. We don't commission. We're not overseeing primary care provision as
No.
we do for NHS trusts. That is quite different. NHS England have that responsibility, but we still have a responsibility around making sure that the messages around safety are shared across the
Okay.
system.
And it's one of the, in Appendix B where we've got those various quality indicators that are already collected, would one of the early ones of those perhaps pick up GP practice incidents, or is it something we need to add? Because I can see we've
No.
got sections by acute providers and
Yeah, we wouldn't
no.
have that. So the way we gather information is through the National Reporting and Learning System, which is where the sort of 2 million incidents a year are gathered.
Yes, huge amounts of information.
Yeah.
Okay, could I just before I forget this, it would be quite a good idea, I think, at a future board meeting to actually have someone from the safety team here, because we've not really sort of engaged directly with them. I think that would be useful for the future.
Yes.
But, Ara,
Just to build on Kathy's point, I wasn't aware on the primary care side. May I just highlight one important point? There is no framework of what incidents are in primary care. We don't even know what they are. We don't measure them at all.
Right.
There's no such thing as missed or incidents in primary care. There
Right.
might be falls in primary care.
Right. Or wrong
Because
diagnoses
you
or
Even that, we don't capture that. In actual fact, a big paper published recently surveyed the whole primary care community. And there is we don't even know what it is. Is it misdiagnosis? Is it, for example, we measure overprescribing of antibiotics, and that is a safety issue. The reason we do that, because that came on the back of antimicrobial resistance and AMR. That's really what the driver. So I think the first piece of work is engagement with the profession to decide what are the primary care safety or incident reporting structure would be. I mean, we know, as you very eloquently described in the 2 or 3 pages later, what the indicators are in a hospital setting. We don't have that in primary care.
okay.
May I ask one other question? Kathy, we just say here about spending, what is it, 500,000 if a hospital is going to special measures and quality.
Yes.
Which, just explain to me what that £500,000 will do.
So, shall I just go over that? So, when a trust goes into special measures, we are responsible as part of the guidance to provide a support package. So, we will provide them with an improvement director, but we will also have them determine, based on the findings of the CQC, what are the things that will help them emerge. So, for example, if they've got big cultural problems, they may need an OD programme or whatever. And with the improvement director and the trust leadership and our regional team, they will put together a list of things and how much that will cost, and the trust will then commission that, and I sign that off to make sure that what they're asking for
Yep.
will lead to improvement against things that were found to be a problem.
So it's injection of talent. The investment will go on new talent that will come in and
Yeah,
help,
it can be
rather
people,
than
it
giving
can
them
be-
the money.
Yeah, so it can be, they have to say what they're going to do with it,
Yeah.
and they may buy in people to help them, they may
Sure.
spend it on from another trust, somebody coming to help them or
Yeah.
whatever, and thus far I think it's been really valuable to them.
Thank you.
any further points for clarification or questions from colleagues? Can we come on to that then, that sort of second issue of the measures, which I found very helpful to have those all in front of me, and really thinking about how they've been developed, how they're going to be used, and particularly thinking from a board perspective, I guess how we could use those as part of our routine reporting and our routine assurance. So, Stephen, you're going to come in first.
It's very, very helpful, but the thing that, I know quality is much more difficult to measure than money or operational performance, but I'd love to be able to see how is quality moving over time across the system. You say it's getting better,
Yes.
Is there a nice graph? I know it's more complicated than that, where we could see that quality is improving over time, and I know measurement is difficult. But
So I think, yeah, absolutely, and I think this is something that we'd very much like to do at the Quality Committee and then be able to bring to the board, because there are graphs and there are things that we can show where things have been moving over time. You can do that relatively more easily, I suppose, for outcomes, because you can demonstrate, you know, what's been our overall, 5-year survival, for example, for cancer or whatever, and all those sorts of things. We can also track, for example, MRSA, what have been the levels for the last X years or whatever. So I think we can do that, and in fact a dashboard has been developed which does exactly that for these measures, and we will be using that, and hopefully we'll make a decision about how much of that the whole board wishes to see. But it is quite interesting when you actually sort of map it out like that.
And of course, trusts actually have these measures in a form that go to their regular board meetings that bring it together now. So there's lots of these trusts that are already looking at the outcomes for patients as well as the outcomes on staff on that. So this is regular day-to-day business for our providers looking at these measurements.
And I guess the point I was to make is it should be regular day-to-day business for us as a board as well. So we need to use that quality committee and these measures to make it part of that. Patrick.
How do other organisations globally do this? I mean, how would someone like Kaiser or somebody who runs a big healthcare system in aggregate get the feeling it's going the right way? Do we have any other international experience we could draw on? Or,
So I think it's worth saying that I think the way that most people have gone is to move very much to SPC charts, so actually looking at the changes over time.
Right.
So for a single organisation, you can do that. What the trick for us to do is, because we've got information about individual providers, and we've got that all laid out, we can see where they are on different things. What we're talking about here is what's the overall for, if you like, the population who have their care in hospital. So where is it for that? So again, I think that use of a chart that shows, actually where were significant changes, when did they happen, and what might have been the cause for that. So if you look back over MRSA, you can quite easily see, if you go back 15 years, we were in a very poor place, and then interventions happened, that Dame Christine Beasley took hold of it, and you can see that change over time.
We can see ourselves globally, we can compare ourselves globally on that.
Yeah.
So there are some measures that we can do that globally.
Sigurd and then Ara.
It's sort of a slightly more general point about all of these. I'd like to urge that we keep these under review and keep updating, because I noticed that quite a few of them are what you might put into the category of faute de mieux. That, in other words, they are measures that I imagine you've chosen because there exist statistics about them, but they're not actually what matters to patients. For example, if you look at ambulance providers, which I'm more intimately familiar with, return of spontaneous circulation, whilst it's an easy one to get your hands on, is actually not what's of interest to the patient. It's discharge from hospital alive that's actually of interest. But it's not so easy to track because you have to track it through the system. And so this one is a faute de mieux measure, if you see what I mean. But that's just an example. I just wanted to make the general point that as we work with this, I think we should work more and more towards measures that measure what for the patient and the family is ultimately rather than just rely on these intermediates.
I think in most organizations that use data, they have access to that data dynamically on an individual basis. So we could sit in any board and discuss these. We're really trying to pick the major disaster that might be happening out there. We're very unlikely to have a major contribution, but we have a huge contribution to play in really getting local clinicians delivering in a local health economy and access to this information, a bit like the productivity data that Patrick's talking about. Yeah. And these need to be individualized. So we can only way to do this through digital. We've talked about this before. Digital application, warning. What is the prevalence of infection in your caseload? And then at a level above, I think the best will be what Peter Provenance has done in Hopkins, when every community and every primary care provider, the whole region, will come to monthly meetings, including the medical director and the CEO, and they will go through one by one as the overall aggregate in terms of the provider organisation. So there's a lot to be learned from there, but the crux of it will be at a local level of individual.
But providing the common language, the common systems, the common measures for that.
So
Kathy?
So absolutely agree with that, and I think that what we know, and through, remember here we are at a board, and we've got regional teams and they interact with individual organisations, and as Ruth has said, each board, each organisation is absolutely looking at their own information, and that very often down to individual clinical teams and so on, so people being able to track. The thing that we kind of need to do, it feels to me as though, and I'm sure Ruth would agree, is that we need to look at the overall trends, because that might tell us something. So for example, if C. diff is starting to rise, what are we going to do? How do we alert the system and how do we intervene? But also, how do we actually make sure that we spot where individual issues are going to crop up ahead of when they become a significant issue? So there's a sort of overall, but also being able to help our regional teams and our local providers get ahead of the curve in a way.
It's absolutely, and I guess what I was trying to get to on this, Kathy, is there are those sort of two levels of intervention. There's spotting a trend happening that you want to try and find a way of dealing with nationally, and sometimes you can only maybe see that from national aggregate data. Then there's another element that is about spotting in advance something happening that someone should have spotted locally but maybe hasn't. But as a board, we need assurance that we would spot it if someone else, I guess, didn't before, and not wait for CQC inspections and things like that. So I think that's what I'd like to see sort of coming out of the quality committee. But sorry, Elizabeth, you were...
I was just going to add, so in terms of the early warning signs, I think we need to look across the data sets as well. So for example, on the infection rates and any links to particular backlog maintenance problems in particular hospitals, or the fact that we've got safety issues around, some safety concerns around the capital. So given that the backlog issue is at the level it is at the moment, I think we can do some further work there as well.
And the important bit is all this is tied up at a regional level as well as at a national level, because there will be some differences between regions, and it will be that community system level that we'll be able to take in some of the really detailed knowledge, and that's where we'll get the early warning sign.
Kathy?
So, and also I think it's worth, absolutely we need to look at individual indicators, but I think it's worth us keeping in our minds that there are some cultural related things that will indicate that things are going off earlier. So for example, if you were picking out of these, what would you really want to save and look at as your one thing, if you like? The staff survey might well be that, and the friends and family, the things that indicate the softer things. And Ruth and I have spent the morning actually in a cross-system discussion around our most challenged providers with CQC, HE, the GMC and NHS England, around are there any, in addition to the ones we already know about, are there any in which people have got early concerns? So in amongst all of this, and I think the Quality Committee will need to take this into account, is there is a softer intelligence around leadership, around culture and so on, that can give you the overall picture.
Okay, can I move on to the sort of question of intervention then, and the triggering of intervention, both at the sort of national trend level and at individual organisational level, and the nature of that intervention, what we know about what works. And a sort of side question for me always on this is consistency between us and CQC about when intervention is required, the extent to which we're using the same intelligence.
So shall I kick off on that one as well?
Unless someone else, is there anything else they want to raise on the same issue, which is that whole intervention thing?
So I think the intervention's on a number of levels. So I think there are some things whereby we use changes in policy or whatever to do in a sort of global way, and Ruth might want to say something about some of the things that have just recently come onto the pitch in terms of some of the infection and prevention and control things. The second is that we may, for example, never events would be something which we've been watching and it hasn't been improving in terms of the number overall. There's a whole cultural discussion we could have around, you know, what leads you to that place. But we have talked about bringing together people from trusts to learn together as a group. So we can do some things where you focus as a workshop or as something, how can people learn together? And then the third bit is where we intervene directly with an organisation and we offer that support, and we would then call upon Adam's team in terms of some of the improvement tools and so on that he has available, and within our own teams and across the region to be able to go in and offer that support. And a lot of it will be around buddying them up with others informally or pointing to where good and great is and asking other organisations to help. So I think, to be honest, there's such a myriad of things. But one thing you might want to know is that on special measures we are pulling together a document which we're hoping to publish at the beginning of November, which actually draws together what have we learnt around the interventions that have been most effective in helping the most challenged improve.
Okay, that would be really helpful to see that. So, Sarah.
So I was just picking back up on Ara's point earlier, which is the best sort of correction in a system is a self-correcting system.
Yeah.
And that instead of us having to spot a trigger and go storming in, it would always be better if the clinicians or the managers had spotted it for themselves. And I wondered what, to the extent that we have these indicators, how much of it we could use maybe the model hospital type model so that they have access themselves. Because, for instance, we know that the Tim Briggs' work on infections in hip operations was most effective in that the surgeons themselves wanted to change their practice. It wasn't that we went in and told them they had to necessarily. So there's some feedback where the information that we give to the clinicians might be more effective than anything we actually have to do ourselves.
I'm going to bring Ruth in a minute, but I wanted Ara to come because Ara talked about the work Patrick was doing as well around productivity in a similar type of approach.
I think the biggest innovation that has happened in the last decade in terms of measuring things is alerts, is alerting, which we haven't yet even tested. I mean, this is not an alert. This is a data by the time you see it, it's about 3 months, 6 months down the line. By the time I see it in my own organisation, probably it's about a month. Unless I'm seeing the patient and I'll obviously recognise it. So that is what we need to be working on. And that data is available. And as I said, we're back to digital. You know, where is, for example, in NHSI, the support from NHS Digital in allowing these things to happen? Trying to design alerts at the moment is considered as research in live data, which infringes, in Fiona Caldicott's current rules of designing algorithms that would produce alerts. So these are all very serious obstacles facing most CIOs, CCIOs in every organisation. That doesn't really come to us. And I think somehow or the other, if we can help them with these, it would be tremendously helpful. Designing an alert, an algorithm, is not considered as part of your routine clinical delivery.
So, I mean, that brings you into some of the things that the Quality Committee needs to get into, which is not just about assuring us and telling us, it's about how do you help other people do it, not just the intervention after the event. Ruth?
And I think going back to that intervention stuff, most of the collaboratives that we're running are where people are asking to be part of them rather than enforcing them. So absolutely, I've got more of a waiting list and more people saying I want to go on to, or can you set up another collaborative for end of life? Because end of life, because clinicians are wanting these resources and these tools. So I think there's a whole pile of learning that we can do on the back of that to see how we can then build on it further about the digital. I think that's the bit of the missing jigsaw really that it could make the biggest leap now for us to go forward with.
Cathy, finally. Sorry, Patrick then Patrick finally.
So absolutely. So if we go back to the self-correcting and the alerting, I think again we need to remember that in an individual organisation, one of the things that we can do is help support and make sure that the leadership is the best they can possibly be, and also that they then have a culture within the organisation of looking at hungry for the data so that they can spot what's happening. And there are some things, so there are some mortality things that do alert actually, so some of the systems will actually do that, but I think Ara's absolutely right to get really timely responsive information so that people can take action. But a lot of it is around the cultural feeling of wanting to learn, wanting to improve all the time, and the best organisations have got really strongly developed quality improvement methodology and service improvement so that you know, that would be, it was our third bit of our key learnings, you know, leadership, engagement and improvement methodologies. And that's what we kind of have got to. We should be unnecessary, really, in all of this, but we can help, I think.
So our aim is to do ourselves out of business.
That would be
Yes,
always
yes,
the aim.
would it be?
Patrick?
I'm just curious, because we're responsible for the whole system. Does the CQC add all the ratings up and say the national score is this? They inspect everybody, they've got their domains. Do they just put them all together and say, we add them all up this year and it scores this, and next year we add them up again and it's moved? And you know, there must be an aggregation. I mean, I'm with Ara coming at the other way, absolutely, on the detail, but somebody's got a whole set of this. As a board, I'm quite interested, is the system moving, and we have a rating system, could we aggregate? I just leave it as a question, Chair.
Yes.
I think
So
Kathy's going to
I
answer
have
it.
an answer, yes. So there's a couple of things. One is they produce the state of care report, which again is coming out shortly for this year's. But we actually aggregate it and send it to the CQC.
That's
So
we
we've-
could see it.
Yeah, we have shared it before actually, where we can see that improving. So the ratings overall have been improving. They do it for themselves. I'm being slightly facetious, but they quite like the way we do it too. So we share it back and forth. But yes, absolutely.
I wasn't
And
aware
that-
of it, forgive me, so that would be really useful to
we'll
see.
be very, very happy to share that, because I think it shows some nice bar charts, doesn't it? And you can just add up for the various domains and so on. You can do all sorts of maths with it.
Fabulous.
But it is moving in the right direction, though at times, I have to say, we have a little bit of slippage as well, but it is overall moving in the right direction.
Well, I did say that was the final question, but you didn't answer my earlier one yet, so which was the consistency between us and CQC in judgment on quality. So one of the things we want to be absolutely clear on is that the system understands what the expectation is from everybody. Do we feel we're in a position where we have a single judgment on quality?
So I think one of the things that we've been, and the National Quality Board have been very focused on, and I think we've all have, is the single version of the truth in terms of the information. And CQC have certainly come out with their latest version of that, which is quite big and complex actually. But in terms of, is our judgment of an organisation's state of quality the same as the CQC's? I mean, we have to remember that they have far more resource in which to go and have a look and inspect, and to some extent we certainly cannot replicate that.
No.
I mean, on the whole, we're working incredibly closely, and I think I do feel for them at times because they've got different teams doing different. They try and have consistency, but I think, given the meeting we had this morning, I think we coalesce around the same group of organisations, being at a particular, either outstanding or at the other end, to be honest. But it feels a work in progress, to be honest.
I did say no more questions, Sigurd, but you're looking at me in a slightly pleading way, so I will let you
Well,
just have
I'm
this one.
puzzled by what you just said. It seems to me that all the provider trusts over which we have stewardship ought to have, for their own good governance, a good stock of quality measures and the data and systems, as Ara was just saying, that would allow them to receive that information regularly. We should simply be able to tap into that and not have to rely on CQC.
I guess the question always on this, and I think it's one that is quite difficult to resolve, is there is something different, I think, from having boots on the ground to actually just seeing the data. So I would sort of expect occasionally, in most cases, 99% of the time, you would expect the data to be telling you what you would also get from having boots on the ground and people wandering about. But there will be occasions where actually walking through the door and sort of smelling the place, and that's where I guess the difference arises. Now, if that only happens on rare occasions, then the system's working all right. If it happens on a regular basis, the data's telling you something and the boots on the ground, the sniff's telling you, then you've got a problem in it. So I guess my bit is that really, is it quite a narrow difference there?
So I think, I mean, without going into them right now, but I could certainly cite organisations where we had thought they were quite good, and then when the CQC went, they just turned out not to be. So I think there are definitely, but they and the other way round. But I think they're a smallish number because we could tell you who they were, and between us probably cover them all. So I think it is a smallish number, and I think that you have to remember that there is a qualitative element to this that isn't all about the numbers. It is about people, and it is about their behaviours, and it is about the culture that you can only really pick up. But I do think things like the staff survey will tell you a tremendous amount, and we shouldn't ignore those. And I think sometimes we have not taken full regard of actually they're telling us something, but it is drifting off or whatever. So I think eventually, if you got to, I remember Mike Richards used to say the reason they have to have the inspections is because you can't totally rely on the numbers. It would be good to get to a point where you'd done so much of that you knew what the numbers meant and could move away from that approach.
But we're not there.
Not quite there.
I'd let that go a bit longer than was planned on the agenda, but I think it's important because we need to have these substantive agenda items about what we're really doing around quality. It would be good to come back to this once the quality committee is properly up and running, particularly on the issues people have raised today about how do we help people identify issues? To what extent can we use digital in a sort of more common approach across the system? But also this stuff about how do we, when we look at the performance of our providers in the NHS on a regular basis, how can we make sure quality is properly integrated into that? But thank you both very much for that, and I look forward to the outcomes of the committee.